everybody. Welcome to another one of our vitamin D study hours brought to you by Grassroots Health. I'm Jen Aliano, the director of Grassroots Health, and I am honored to have Dr. Sunil Wimalawansa join us today. And he's going to be talking about the calcium-magnesium ratio or calcium-magnesium balance and how it relates to vitamin D. So a little bit about Dr. Wimalawansa, and just before I started today, we were talking about how he was one of the very first Sri Lankans to climb one of the Himalayan peaks, and he was presumed dead. They even had a ceremony for him, but he survived, obviously. And so now he is one of the most distinguished vitamin D researchers with many papers, many peer-reviewed publications on vitamin D. He's also a endocrinologist, a clinician scientist, a expert on micronutrients, including vitamin D, obviously. And he has won many awards. And I also want to say a couple of the other intriguing things about Dr. Wimalawansa, and his full bio will be on our website, updated on his scientist page. But he was actually, he could be considered the inventor of telemedicine. So he opened the first known telemedicine clinic in the Mexican border towns here in the United States. So, but we are here to talk about vitamin D. And before we start, let's go over some important notes. Please submit your questions for Dr. Wimalawansa in the Q&As. I did enable the chat today, I believe, so you can also discuss amongst yourselves in there. I am also always open to feedback and suggestions for this topic as well as future topics. Again, this webinar will be recorded and posted to our website and our YouTube about a week after. So before we start, remember you can get your home vitamin D test kits from Grassroots Health. You can also measure your magnesium along with other essential elements and toxic elements. And then remember, we are doing this on Wednesdays regularly. I may be switching it to every other Wednesday. It's a lot of work. It's a lot of fun too. But our next scheduled ones, we have Dr. Richard Chang speaking about vitamin D resistance on December 17th. Followed by Dr. Michael Hollick, who will be discussing the 2024 guidelines and clearing up confusion around those. January 21st, we will have Dr. Barbara Boucher on metabolic syndrome, insulin resistance, and type 2 diabetes. So again, email me with questions, stories, feedback, suggestions, Jen, at grassrootshealth.org. And we are a 501c3 nonprofit, and it's the end of the year, and your donations are always appreciated. So let me just get this switched over to Dr. Wimalawansa. And let's make sure, okay. All right. Welcome, Dr. Wimalawansa. It's a pleasure to have you here today.
Jane, thank you. Thanks for joining us for this 1 hour presentation today on this vitamin D study hour. So we are going to focus today on calcium magnesium balance, which is extremely important but highly, I would say, neglected area topic in clinical point of view. But I will address that as we go on. So originally, this is what Jen asked me to talk about, one of the papers we publish about the minerals in general on toxicity and deficiency. But here's what the minerals in and human health looks like. It's a jungle. It's extremely complicated, and because each and every mineral we take and need for our health is interconnected with something else. So you cannot discuss with any mineral like iron, for example, without talking about the other minerals. So somebody to talk about one iron, one mineral, zinc, or what is going to be very difficult and it's misleading because they are interacting all the time. In fact, there are something like a 45 or close to 50 minerals are necessary for our full functioning of the body. So, nutrient points of view, there are two kinds. One is a macronutrients, which is everybody knows carbohydrates, proteins, and fat. And then the micronutrient comes with the vitamins, minerals, and cofactors. I will address these very briefly, the vitamins and cofactors. The, the macro minerals are mostly the calcium, magnesium, and phosphorus. These are the three predominant minerals we have. Calcium being predominant and is in bones. Microminerals are iron, zinc, copper, iodine, selenium, manganese, and the list goes on. So, minerals are vital for our growth and almost all physiological the reactions in the body and also the physiological functions, the muscles and nerve conductions. In addition, minerals helps to maintain the fluid balance and the pH or the acid-base balance in our body fluids. Without that, we will not be able to survive. In addition, minerals are also work as a cofactors in almost all enzymatic and coenzymatic reactions. In addition, some minerals like selenium, zinc, and copper have specific function as an antioxidant by themselves, in addition to the other functions. Similarly, iodine, for example, is a crucial factor in thyroid hormone. Without that, thyroid hormones will not function. It's a figure from Rasik and us on the nutrients early this year, showing the complexity of some of these macronutrients, what we are micronutrient we are talking about. However, today we are going to focus down to magnesium and calcium predominantly. So, what is the importance of calcium magnesium balance? To approach that, I like to discuss the two components separately to start with calcium, which is the most prominent extracellular components in the body. 99% are located in the bone, but extracellular, not within the bone cells, but outside in the matrix of the bone. Calcium is essential for muscle contraction, nerve conduction, and blood clotting, etc. Even the slight fluctuation of ionized calcium, not the total calcium in the blood, for example, if the 5% increase or decrease of ionized calcium can be lethal to human beings. Therefore, there's a built-in system like vitamin D PTH axis within the body to prevent that sudden changes of ionized calcium happening. So these are active within seconds to seconds to maintain our ionized calcium very tightly in individual so extracellular fluids. So, importance of calcium and magnesium balance. The next component is a magnesium. Magnesium is essential for energy production, as indicated in the ATP, and it also regulates the ion channels, which is communication from cell to cell, and more importantly, it's a counterbalance of calcium action. It's a yin and yang kind of phenomena. It's a negative and positive reaction with calcium. And this counterbalance is essential in the brain, muscles, kidney, prostate, and all other systems, particularly in the vascular system. So low magnesium increases cellular stress as well as it increases possibility of calcium to act more aggressively in tissues as we see the next couple of slides. including the extracellular or soft tissue calcification. This is a complex slide from one of my colleagues or co-authors, Patrick Chambers, in 2024, just to illustrate that vitamin D synthesis, as depicted in these blue circles, 7-dehydroxycholesterol to start with, then converted to cholecalciferol, D3, 25-hydroxy, and then 125D, which is the active form of vitamin D, which is also called calcitriol. And then you get deactivated to 24, 25, and 125 to 20. Whenever 24 generated within the vitamin D become deactivated. So all these reactions requiring magnesium, as you see in this blue circle, in the absence of magnesium, was insufficiency of magnesium, all these steps will be dysfunctional. Therefore, the entire vitamin D axis will be dysfunctional. In addition, synthesis and secretion of parathyroid hormone from the parathyroid gland will be affected significantly. Not only that, actually, the secretion of all hormones except the pituitary gland got also get affected in the absence of or less amount of presence of magnesium. So magnesium is a crucial element which most physicians are continue to neglect for multiple reasons. So this problem arises in the West, particularly in the Western diets. Western diets we know as now is predominantly calcium high, but magnesium low. This has getting worse over the past 4 decades. So long-term imbalance with high calcium and the low magnesium dietary intakes, it favors soft tissue calcification as we see in the senior citizens in the Western countries. And you can see this in the kidneys, hypothalamus, liver, prostate, and blood vessels. In addition, more importantly, this calcification in some tissues like prostate, for example, is also promoting cancer formation. So one of the reasons why for having excess cancers in Western countries, industrialized countries, is the calcification of prostate gland itself, not the vitamin D itself. So here are some of the facts or unknown facts about the vitamin D, or magnesium. So this is the average weight of adults in Western countries. We have about 25 grams of magnesium, and it's the second most prevalent intracellular cation. So 99% of these are in muscles and in soft tissues, and 60% of that is within bones. So only 1% of this actually presents in the extracellular fluid, basically blood and the tissue fluid. We'll come back to that in the next slide. So sources of magnesium in common diets include the whole grains, dark greens, gr- vegetables, most vegetables, legumes, nuts, seeds. Banana is a good source as well, so as seaweed, seafood. One of the issues, unlike calcium, so only a third of the dietary magnesium generally gets absorbed. And 80% of magnesium is also excreted by kidneys through urine. When we measure the serum magnesium level, we are really measuring in the 0.5% of total body magnesium. So it's not surprised that it is not a good indicator of whole body magnesium. Nevertheless, every clinician in the world uses the serum magnesium level as a surrogate marker for magnesium status. Why? Because it's the other measurements for magnesium is cumbersome and expensive, like red cell or intracellular calcium measurements. Last two bullets basically to show that the normal levels of magnesium and below zero point 0.7 millimoles are considered as a magnesium deficiency. Again, with the caveat that what we are measuring is a 0.5% of total body magnesium. So, among the functions of magnesium, it acts as a catalytic component of the enzymes and the coenzyme. So, without the magnesium presence, most of these enzymatic activities does not function properly. In other words, they are dysfunctional. Similarly, they are also worked on the ion channels activity, that is communication between cells through ion channels. And in addition, it also stabilizes the membrane together with vitamin D. They work together to stabilize membrane and prevention of leaking fluids and ions through membranes. And the magnesium also included is necessary for cell proliferation, differentiation, apoptosis, or cell death, and new blood vessel formation, so-called angiogenesis. Finally, it also important on the glucose and lipid metabolism. Therefore, the people with diabetes and lipid abnormalities, magnesium deficiency can have a tremendously negative effect. And some of the patients that we have seen, it's difficult to control diabetes or lipids all over the place. And if you look at carefully, they have a significant magnesium deficiency. Rather than manipulating with the insulin and all the other medication, simply put them on even magnesium supplements or altering their diets to increase the magnesium intake will improve their diabetic control significantly. It can also affect the immune system and the nervous system functions. So, again, together with the vitamin D, it has a predominant effects on the DNA and RNA synthesis, as well as the protection of both DNA and RNA. It also contributes to the so-called steroidogenesis, which is basically the synthesis of steroids, including steroid hormones. So, in the absence of less magnesium, production of these components become less effective. In the clinical point of view, one magnesium deficiency is one of the reasons for muscle cramps, not all, just one of the reasons. Twitches, fatigue, irregular heartbeats, so-called cardiac arrhythmias, osteoporosis, hypertension, and drug-resistant migraine. That's one of the very important things. Now, let's come back to the measurements of magnesium. I'm not going to go into details. As Jen said, that this will be recorded and will be available as a YouTube video within the next week or so. So you can go back and review this slide in more detail. Therefore, I'm not going to go through um, some of these slides in detail, except to say that there are various methods to measure more sophisticated methods like renal magnesium excretion, magnesium load test, urinary magnesium test, and this is a very common test. You can request red cell magnesium, which is better reflect the total body magnesium. So the fundamentally is with the deficiency or excess of any of these minerals can have a negative health consequences. Another important facts for children point of view, if the kids and adults and particularly drinking excessive amount of fizzy drinks, cola drinks, they have a phosphoric acid as a preservative. pH is about 1.5 to 2, very acidic. So these phosphates can adds up, can cause phosphate toxicity, which can cause bone abnormalities, which can cause cardiac or cardiovascular calcification, even in a premature or prematurely in adolescents and early young adult stages, if they are having this phosphate toxicity secondary to overdosing with phosphates. So, on the other hand, having a balanced diet, typically providing the sufficient minerals like calcium, magnesium, and others, So they will have a generally had a very well functioning system and work well with all the other hormonal function with a disease free status. Over the past 4 decades, or maybe even 5 decades, the importance calcium has been overemphasized, overprescribed, and I can remember 15, 20 years ago, the recommendation for calcium was 1,000 to 2,000 milligrams, 1 to 2 grams per day, which is extremely high doses. We knew that bit later that can cause problems. In fact, it has shown to be a problem, including the cardiovascular calcification. So current recommendation for calcium, at least in my point of view, even for osteoporosis, not to go anything more than 400 to 500 milligrams per day, especially should be taken after the after supper or the night meal. That should be sufficient. But the issue is not the calcium even in the osteoporosis, it's a lack of vitamin D. So if you're going to add some vitamin D, even the addition of calcium may become redundant because vitamin D itself will increase the absorption of calcium in the intestine. Therefore, you may not necessarily need to give calcium supplements in these patients or people. So what are the reasons for hypomagnesemia causing problems? So primary reason is lack of ingestion of the magnesium-rich food, which I mentioned about a few minutes ago. That's the commonest reason. Then there are three other reasons actually. Second is GI, gastrointestinal losses, decreased absorption due to various reasons, means bowel diseases, parasites, and all kind of diseases affecting the intestine. Then there's another group of renal losses, the loss from the kidneys include the diabetes, chronic metabolic acidosis, renal transplant, and acute tubular necrosis. And there are about 10 or 15 different disorders related to kidneys, which can cause a significant magnesium losses needing replacement. Nevertheless, replacement should be very careful in renal diseases because there is no mechanism to control the absorption retention. So they can go from the deficiency to toxicity pretty quickly if one is not careful. The last common cause is the using the diuretic can also contribute to magnesium losses, so as sodium and potassium. Now, this is a question several people also ask me, so I created 3 slides, which I'm not going to actually go through in detail, except for the first slide. There are 9 different supplements available in the market. But in this particular slides, the first 3 are the one commonly available. So each slides, I have also identified the pros and cons on each magnesium supplement. So you can go back and read them and identify what is best for you because there are a lot of variation between these 9 supplements. For example, magnesium oxide is a very low absorption, but it may be tolerable, but it can also cause diarrhea in many patients. Second one is the magnesium citrate. Its absorption is a little better, but still can cause cramping like symptom. But absorption is significantly better than the magnesium oxide. Out of these 3, the glycinate is probably the better one for absorption and the ability to tolerate. And prices wise, the glycinate is a little higher than the first 2, but I think it's not significantly higher. The others are the magnesium malate, taurate, and orate. Now, these 2 I put together because these 2 are marketed. Taurate and orate are marketed for cardiovascular for reasons. I'm not recommending these for cardiovascular reasons because they are clinical and scientific evidence are very few. So they are not coming to a recommendable standard, but their real marketing is for cardiovascular health, blood pressure, and for cardiac failure kind of thing. The next one is L-threonate. Threonate magnesium is particularly marketing for cognitive support and brain function because the claim is that it crosses the blood-brain barrier. Again, the data, scientific data on L-threonate is not sufficient for me to recommend it to take it for this particular reason. The last three are the sulfates, chloride, and lactate, which is really hard to get buy from the market, and also should not take as a supplement because they have a lot of problems and really should be only used on a hospital basis for intravenous and other specific indications. So, how to avoid the side effects? This is a question a lot of people are asking. It's not a magic about it, it's a common sense. You have to shop around and see what out of the what these nine, what is the most suitable for you because every person is different. Just like in calcium supplements, one is can be better than the other one for any given person. So you have to try and trial and error. You have to try and see which one is better for you. Always start with a smaller dose, not the recommended dose, maybe one fourth of the dose, and after a week or 2 weeks, slightly increase the dose. Always take the magnesium supplements after food, especially in the night. After dinner, you can take that. And avoiding take with other medication is possible because some of these actually interact with the medication like antibiotics. So those who with any renal impairments or kidney function abnormalities should be careful and suggest that you work with your own physician to see whether what kind of a supplement you should take or should not take. What happened with when you have the high calcium and low magnesium, as is majority of the North American residents, or actually most of the Western, anybody with a Western diet? So, in the absence of magnesium counterbalance, so calcium predominates, and it also has these adverse effects predominate. That includes a tendency to soft tissue calcification in kidneys, blood vessels, prostate, and liver, as I did mention in my previous slide. So these things should be avoided because these are really irreversible harm to your key organs just because you don't have enough sufficient magnesium in your diet or supplement. So, in addition, imbalanced calcium magnesium ratio stresses your body system cells and the PTH vitamin D system. I'll show you in a second so what that I mean. Here's a slide, another slide. I'm not going to go through it, but just for you to review later to show that with these hypocalcemic ratios, hypercalcemic ratios between the two, you can have the various etiological conditions. You can generate adverse effects, like in the chronic kidney disease here, or cardiovascular, gut. So please go back and have a look at it when the video is available for this particular slide. How does the vitamin D fits, as Jen mentioned on her preliminary remarks? Vitamin D in general increases the calcium absorption from the gut. It's increases what you call the fractional absorption of calcium from the gut. So with low magnesium, in the presence of low magnesium with higher calcium absorption, it can cause problem. So one need to be mindful of taking some additional magnesium containing diet. Or if that's not possible for some reason, at least take some supplements in the night. They're not expensive. Similarly, the vitamin D balance with PTH will get affected significantly in the presence of low magnesium, and actually there are some other minerals also going to get affected. So excess calcium in the presence of low magnesium and higher vitamin D level greatly increases the risk of soft tissue calcification, which is 100% avoidable. So here's a way to calculate the vitamin D dose. So this is another question several people have asked me. So I'm going to this had been published in several papers, and I also put the DOI numbers, and you can retrieve those papers and have a look at the original ones, how the calculation are derived. What you would like to consideration the last three lines here. Anybody with non-obese, you can calculate this by 70 to 90 international units per kilogram body weight. If your weight is 70, you multiply 70 into this one, then you get the number of international unit you need to take on a daily basis. So moderately obese, the dose is going to go up. Morbidly obese, you can see that the dose is going to be extremely high, about 5 times, 6 times the dose of a 70 kilogram non-obese person is taking. So this calculation is actually eliminate the guesswork and give the approximately correct value of higher dose and necessary for obese people to take vitamin D correctly to achieve the real therapeutic level between about 40 to 60 nanograms per milliliters. Here's the dose response curve we have published some time ago. This is from 2023 and other areas, just to show you a couple of things. I know that Dr. Richard is going to deal with this particular aspects next week, next Wednesday is his talk. So here's what I'm going to do. When you're vitamin D deficient, when you give vitamin D, it increases the benefits rapidly, particularly the musculoskeletal benefit. There are people I have treated many, not dozens actually, hundreds of them, and the wheelchair-bound patients with a vitamin D of 5, 6, 7. When you give a higher doses like 100,000, 200,000 of interaction unit, in a weeks they start to walk. So the muscular neuromuscular effects will be disappeared, and they able to gain their gait and ability to proximal myopathy will disappears because of the lack of vitamin D deficiency. Then once they reach the plateau from about 40 nanograms to about 80 nanograms, that's what we call the sufficiency range. Uh, there's no much added benefit. This is the area I think the Dr. Richard Zhang will add more, because there are a small group of patients who will gain tremendously by giving much higher doses under medical supervision. These are the group called the drug resistant or the vitamin D resistant syndrome, like drug resistant migraine, asthma, psoriasis, and all these things. But the adverse effects will not start until about 150 nanograms per milliliter in most patients, most people. So the commonest sources of generating vitamin D3 is exposure to ultraviolet B radiation. It's no secret. We all get, when you go to the sunshine, you're walking around, we get, whether we like it or not, we get some generation of vitamin D. So when UV rays strike on our skin, it converts the 7-deoxycholesterol, which I mentioned in one of my previous slides, and it get converted to D3, which then get absorbed, bind into its binding protein, go to liver, and get converted to 25 hydrox vitamin D. So this is where we are supposed to get at least 75% of our vitamin D, preferably close to 90%. As I show you in the next slide, which is extremely important to understand, this is not a synthetic compound. So most commonest source of generating vitamin D3 is coming from sheep wools. So this is exposed into 7-deoxycholesterol to UV radiation and generate D3. Per year, per annually, they make several metric tons of vitamin D3 using this method generated from sheep. So again, the myth is that vitamin D3 is a synthetic component is completely wrong. So these are coming from the natural sources, that D3 comes from animals and D2 comes from the plant. The second sources, which is come from most from the vegan point of view, the plant comes from the lichen derived, which is basically fungi, mushrooms, and algae. And there are some sources of D3 coming from that route too. Important thing is these are not synthetic D3s. So when there's an optimal ratio of calcium to vitamin magnesium, there is physiological vitamin function restored, optimal pH regulation, stronger bones, and there's a reduced risk of vascular and soft tissue calcification. That's what we eventually try to achieve. The good health with the no soft tissue calcification. All the calcium should direct to skeletal tissues, not to soft tissues. So also they have the better whole body minerals homeostasis and retain our neurological functions. It's a complicated slide just to show a couple of things. Again, this is from originally from Dietal and my colleague from Chamber republished it. And just to show that it's a calcium to magnesium ratio with the normal range here, high calcium, the low calcium. In the case of low calcium to magnesium, that means low calcium, high magnesium, increasing calcium alone has shown to be less effective. In these people, it's essential to provide vitamin D in addition. So, couple of more noteworthy things. Many illnesses, especially any infection and autoimmune diseases, post-surgery, for example, also con- significantly consumed vitamin D3 and magnesium both. So during the infection process, the patient may be coming into hospital with a normal or borderline normal vitamin D. By day 3, day 4, he could be in a significantly vitamin D deficient unless the patient is supplemented with vitamin D. This practice is never ever done in hospital yet, despite we having the knowledge that this patient get significantly vitamin D deficient in hospital. Therefore, what happened is that the hospital length of stay become unnecessarily delayed. Instead of going home in day 4, day 5, they stay for 7, 8, 9 days. And also they'll get admitted to unnecessarily get admitted to intensive care unit. It can be prevented by administration of oral administration of D3 or at least this activated form of 24-hydroxy vitamin D, which is much more efficacious. Unfortunately, this practice is no one I know is practicing this particular really valuable piece of clinical practice. So this alone, this infection associated reduction is alone impair the calcium magnesium dependent outcome. So the whole scenario is going to get significantly worse in the presence of infection or any other diseases in the absence of providing them with the magnesium and vitamin D. Unfortunately, in clinics, in hospitals, even in the ICUs, we rarely assess the magnesium level. Even if the level is assessed, as I said before, what they assess is significantly assessed in the blood, which is 0.5% of the total body magnesium compartment. So it's not remarkably good, but at least it's the best is available. In addition to that, the D3 deficiency also linked to gut abnormalities, so the particular the dysbiosis, the bacterial abnormalities, and causes the further absorption abnormalities of minerals. Could add a couple of vitamin D, vitamin K2, because again, I had a couple of people send me text asking some question about K2 regarding this one. K2 is relevant when the calcium and vitamin D intakes is moderate. In the sense that so for example, somebody is taking, say, 70 or 70 kilogram year old person taking, say, 7,000 international units of vitamin D or 50,000 international units of vitamin D once a week. So beyond beyond that, it's advisable to take K2 supplements either, but the 200, something like 200 micrograms per day or about 800 to 1,000 micrograms so once a week. So one of those, whatever is available in the market. So at the very low doses, not going to need it. These are prophylactic doses to presumably to direct that excess calcium coming into the circulation towards the skeletal tissues instead of going to soft tissues. So balancing magnesium with calcium does not replace the K2's role in activation osteocalcin and matrix protein. That's another myth that some people are thinking about it. So K2 has independent action on bone, on calcification. So considering the big picture with a patient with somebody with osteoporosis, for example, who are commonly giving calcium and vitamin D, or somebody with a low bone mineral density as measured with the DEXA method, or fracture history, diabetes, kidney disease, or cardiovascular risk. So calcium K2 is a good option to include in their regimen to prevent soft tissue calcification. So somebody with a modest calcium intake or higher dose of vitamin D and getting K2 is a reasonable thing. But K2 does not necessarily need to be taken as a capsule or pill, but you can get it from the fermented food, certain cheeses, egg yolks, and other food components as well. Here's a kind of a complicated slide, and let me see if I can explain it a little better. It's from the Sasrasanov et al. Published by Grassroots as well. So, but it gives a lot of information. So, what we are looking at is optimal calcium to magnesium ratio right in the middle, there we are supposed to be. Those who are having the Western diet is drifting towards the higher end of calcium. Those who are on the Asian diet are shifting towards the low end of calcium with higher magnesium. So on the Western diet, folks or Western countries, they'll have a higher calcium, less magnesium. So increasing magnesium may reducing the risk. Whereas if you add more calcium, like calcium pills on top of it, it actually increases the risk of soft tissue calcification. So reduction of calcium is indication in these circumstances. Whereas those who are on Asian diet, irrespective of wherever you live, it doesn't matter whether Europe or US or in Asia, you have a less calcium compared to magnesium in that ratio. So this scenario, the reduction of magnesium or increasing calcium, perhaps both is indicated in this situation. In addition, in the Western, those who are taking Western diet, because of the higher calcium intake, it's also good idea to consider proactively using K2 to prevent soft tissue calcification. Again, this is really, I have not seen anyone practicing this important clinical guidance. So magnesium deficiency impairs all steps involved in the vitamin D activation, as I showed you at the beginning, the complicated slide, and the deactivation as well. Vitamin D receptor function get impaired, so the whole vitamin D axis and the PTH axis gets impaired as well. Calcium and magnesium are also antagonistic, as I said, yin and yang syndrome. So the balance is crucial for our healthful physiological functions. In addition, as you are known about calcium channel blockers, so this also interfere with the calcium channel blockers. PTH regulates the calcium magnesium in the same way. Nevertheless, it's important to note that calcium is the primary way to determine the the function of PTH, a release and synthesis and release of calcium. High calcium magnesium ratio also amplify the calcium formation, as already said that. In addition, it may also oversuppress, or there are some instances actually exactly the opposite can also happen with the PTH, even more complicating the situation. So you have to be very careful on these situations. So this slide again, I'm not going to go through, but just to say that adverse effects of calcium get amplified in the presence of ratio abnormality. So maintain health relationship between vitamin D, calcium, magnesium, and phosphate are essential for bone health, hypocalcemia, avoiding of soft tissue calcification, and healthy activation of physiological reaction, and avoiding of the chronic diseases, including calcification. So in summary, the calcium magnesium ratio we try to or should keep it between 1.7 and 2.6. This is on milligram to milligram, and high calcium to, to magnesium or low magnesium often seen in the Western diet, which can be easily corrected if you are cognizant of what's going on with your diet and measurement of serum magnesium level. And finally, the vitamin D deficiency and low calcium intakes are often seen in the Asian diet. So these are the two different scenarios of the same problem, two different ends. So magnesium deficiency furthermore compromises the pH-dependent calcium absorption. So the whole thing become really impaired and pushing towards a higher calcium to magnesium ratio if one is not uh, taking precaution for in this situation. I think this may be my last slide. So maintaining proper calcium to magnesium ratio is essential to globally to avoiding magnesium deficiency, which is very prevalent in Western societies. Study data support that maintaining optimal calcium to magnesium ratio is benefits many disorders, not only cancer prevention, as well as other disorder prevention and worsening of existing disorders. So, optimizing the calcium magnesium ratio is a highly cost effective, globally effective strategy to improve the metabolic health and reduce disease growth. I suggest that before adding another medication, doctors should consider adjusting the diet or adding the magnesium or something simple to do that before complicating the situation further. Thank you for listening. Jen, let's have the question and answers.
That's such a cute picture. I love that. Fantastic presentation. Thank you so much for all the detail you included and for including some of the questions that I sent you earlier. I have my own question to ask before I get to some of the other questions that were sent in or have been submitted today. Uh, so we know that there's only what 0.5% of the body's magnesium in the serum, a little bit more in the red blood cells. Grassroots Health, we measure the whole blood magnesium. Um, but even so, what is the clinical significance then? In my understanding, it's great for identifying people who are very deficient in magnesium, but what else can we gather from measuring the serum or the whole blood magnesium?
Whole blood magnesium is a very useful indicator those who are sick and in hospital, not from the outpatient point of view, it's not worth it. And especially before transferring any patient to ICUs, I really suggest that to do a red blood cells magnesium, at least request that so that the ICU folks will have that access to magnesium, and correction of that magnesium deficiency prior to transferring might actually prevent the patient going to ICU and recover quickly in wards. That's the first thing. But the second thing is actually to the measurement of intracellular magnesium a little more expensive and available only in certain centers. Therefore, including yours. So therefore, the people are not regularly using it. But at least in my point of view, the serum magnesium level should be a part of the routine uh, health panel, should be included, but it's not there anywhere in the world today. Calcium is included, but similarly, magnesium should be included so that anybody can make their own calculation from the calcium to magnesium ratio, at least using the health panel without making any additional costs.
Mm. And they would need the calcium level measured as well,
Yes.
which was that brings me to my next question that was submitted. In my training, I was told that once serum calcium is 9.7 to 9.8, it is recommended to not give more than 1,000 IU of vitamin D because high vitamin D can drive serum calcium higher. Is this true? And if it is true, what do you do to help raise a person's low vitamin D if the serum calcium is in the 9.7 or higher range?
Thank you for the question, but whoever the person advised is completely wrong, given the wrong advice. The 1,000 international unit of vitamin D is what we prescribe for infants, not for adults. That was 30 years ago. Anybody prescribing 1,000 units for adults is practicing outdated medicine. So, secondly, the prescription of normal amount of vitamin D, like 5,000, 6,000, or even 7,000 for somebody with the normal calcium, it is not contraindicated because the body has a mechanisms to prevent the alter the calcium metabolism, including absorption, excretion, very efficiently to prevent hypercalcemia and getting excess calcium into the body, unless with the exception ill patient or somebody with renal failure. So there's no reason for anybody to somebody with calcium serum calcium of 9.5 not getting reasonable amount of vitamin D because harm is much more than giving, not giving.
Right, right. And I know in the Coimbra protocol that uses the therapeutically high doses of vitamin D, they are very good at restricting calcium from the diet and avoiding all supplemental calcium. So that could be another consideration. Um,
Yeah.
Another question. So this is about calcium supplementation and when it might be recommended. So in cases of osteoporosis, would you recommend calcium supplements and in which form? Which kind of tags along with another question, which forms or types of calcium are better than others?
I think I addressed that question by giving those the 9 different magnesium supplements. So I suggest that the person who sent that request go back and read that detail because that 3 slides give all the information necessary for you to make the decision what calcium will be good for you because it's a huge individual variation. So I cannot recommend say that this one is better than the other. You have to shop around and see, take one, if not, go to the next one. They're not expensive. They're just $5, $6. Get a small quantities and find the one you can tolerate it. That's the key thing. Just like to find the best diet for you to lose weight. Exactly the same mechanism. Find the best one, then increase the doses, what you can tolerate it. So again, suggestion is to please read that 3 slides with the 9 different supplements and find the best one for you.
And it might be also covered in your paper that we recommended as part of the homework too. And then, well, I guess to repeat part of that question, and when would you recommend supplementing with calcium versus increasing a dose of vitamin D to increase somebody's calcium level? Are there certain symptoms, conditions that you would really emphasize the importance of calcium supplementation along with the vitamin D and magnesium?
I think that I touched briefly during the presentation. If you are getting the recommended vitamin D doses, as that's a 3 lines I said that how to calculate the vitamin D doses for any person based on the BMI and the weight, you do not need to have a calcium supplement because that dose actually increase the calcium absorption necessary to the right level automatically So it will adjust the available dietary calcium increase to compensate the calcium absorption so that getting new additional tablet forms of calcium become redundant. And also with the doses of vitamin D, about 6,000 and above, and 50,000 international units once a week, additional dose of calcium could be even harmful.
Hmm. Wow. Okay. And I think that, let's see here. So, one of the questions submitted during the presentation, how do you dose calcium, magnesium, and D3K2 for supporting healing a bone? And I'm wondering if that's for a bone fracture. So, even in cases of bone fracture, you might not need to supplement with calcium.
Not really. If you're giving the normal, the average required amount of vitamin D, there's no reason to give calcium, additional calcium. I mean, we used to give that 20, 30 years ago because we didn't know that how how much efficient our intestine is in improving the fractional absorption of calcium is very efficient. Unless your gut is sick, like having some intestinal disorder or the bypass surgery, so that's a different issue. So in a normal circumstance, I don't think you need to have a calcium supplementation, even for osteoporosis. Other than if you really want, you can take one tablet of 400 milligrams calcium in the night. Certainly not more than that because it can be harmful.
Hmm. Okay, thank you. Another question submitted by Richard. To control leg muscle cramps, I take 750 milligrams of magnesium oxide in the evening right before bed, along with vitamin D, C, B complex, and zinc. However, if I have a dessert that's high in sugar, I may still have an episode of leg muscle cramps. I will then take another 500 milligrams of magnesium oxide and then I can sleep. Do you have an explanation on why this happens? Does a spike in sugar cause magnesium to be excreted by the kidney? Interesting question.
You know, as usual from Richard. It's a good question. Actually, two things. One is the absorption of magnesium oxide is the lowest among the nine components. For example, the difference between magnesium oxide and magnesium glyconate is about almost 2.5 times better absorbed. So maybe worth switching to magnesium glyconate and reduce the dose actually a little bit and see whether that will do a better rather than increasing the magnesium oxide itself because that can cause a lot more GI problem also increasing the magnesium oxide. I'm not aware of the interaction of magnesium and the glucose on the renal tubular excretion of that area on glucose excretion really. I do not know.
Okay. Um, a question following that I have, okay, so how do I know that my level of body calcium is too high from a simple test at home? Or how can you know if your blood calcium is too high? Or can you know without doing a blood test? So, in other words, what is a way that we can kind of understand the health of our calcium level without measuring?
Unfortunately, it's virtually impossible to rely on the clinical signs alone in hypercalcemic situation. I can say that. I mean, the gritty eyes, irritability, twitching, all those are signs of dehydration or signs of hypercalcemia. But these could be signs of depression or some other anxiety, that kind of thing. So, without having a calcium measurement in blood, it's impossible to say categorically that whether you have in the normal or hypercalcemic status. Now, even with the hypercalcemic status, if you have the total calcium, it's always a good idea to get a ionized calcium or at least a calculated ionized calcium level, which is basically, excuse me, the total calcium adjusted for serum proteins basically is a calculation because that those things will give a good idea whether you have a issue or not having an issue. Because, for example, if you have a high protein level in the blood for whatever the reason, you're having a total calcium of 11 is not hypercalcemia, that's normal. And if your calcium protein is low, like 4, and then you are having a 10 milligrams of calcium, that's hypercalcemia, could be. Because the 50% of your calcium, or more than half of your calcium, is bound to protein. So higher the protein amount, higher the amount you get in bound form. So you need to have a comprehensive analysis to give us the proper explanation of what's going on in vivo.
Right. Yeah. Measuring the blood levels, and then there's the urine testing as well.
Yeah,
Um,
the two things. One is a measurement of blood level. Other one is the 24-hour urine calcium. Usually, the cutoff limit for about 70 kilogram person is about 400 milligrams per 24 hours, but that varies from female to male as well, the 300 to 400. But again, if the hypercalcemic status, true hypercalcemic status, you're talking about the 600, 700 milligrams of calcium in urine. Huge increase.
mhm. And I love how you mentioned dehydration. Does dehydration actually lead to hypercalcemia? Meaning, if you're not getting enough water, that could cause additional issues related to calcium. And then to piggyback on that, making sure that you're getting enough water is important to that calcium to magnesium balance too.
Indeed, and because if somebody going to the blood test and person is not taking anything by mouth and is dehydrated, it is not the normal blood test you're going to get it because altered blood test because the vascular volume is constricted now. Your hematocrit or the PCV or the blood cell volume is now increased from 50 now probably 60. So remaining the blood volume is only 40 now. So everything gets constricted. That means more concentrated. So your protein is get concentrated, your calcium is gets more concentrated. So it's it's artificially elevated numbers you are getting it. So make sure that make it a point that your hydration level is good whenever you go to a blood testing. But even if fasting, that doesn't mean you can't drink water. You can drink water, and you
Mhm.
should hydration should be normal at the time of taking a sample of blood. It's very important.
Right. Another question, how do high levels of magnesium affect the kidneys?
It's a tricky question because the when the kidneys start failing, it goes crazy. Really, very difficult to predict how the kidney function because it can even cause hypokalemia, but hypomagnesia, but most of the time hypermagnesemia. As I said right at the beginning, 80% of the magnesium is excreted by the kidney. So if the kidney is unable to excrete, just like urea get accumulated, creatine get accumulated, magnesium will get accumulated with other toxin. So again, what you're looking at it in the blood is artificially accumulated magnesium, not true values, because kidney function is slower. But it could be again partly due to dehydration. So it's a combination of things. You have to be figure it out what's going on.
Right, right. So I'm only going to ask these last two questions because we are out of time, and I really appreciate you sticking around and answering these. So somebody is just asking if you would recommend using a UVB lamp to generate vitamin D from the skin. She uses a Asperti. There's a lot of great brands out there, but do you think that's a good idea?
I think lots of my colleagues in the vitamin D field doing that. I'm sure you can ask the same from Dr. Richards next Wednesday. He's a good fan of that too. So as I think my colleague has a lot of experience on that than me. So, eh, but you have to be careful of two things. Firstly, the type of lamp you're using, because some of the lamps are not certified and they actually generate a lot of UVAs, can cause cancer. So the secondly, there's no regulatory if regulator generating what kind of UVs are generating and the distance from the lamp to the skin and
Mhm.
the duration you are recommending, depending on the type of the skin. and somebody younger person skin versus the older person. There are a lot of variabilities there
Right.
to find out what's the right duration and the intensity, the dial you can use it. So I cannot generally recommend that you can buy a lamp and just use it. You have to work with somebody who working know about these things properly and use the recommended and FDA approved kind of lamp, so to be safe, because you don't want to have a very good tan and vitamin D levels and end up with a cancer.
Right, right. And I feel like that's a perfect opportunity for me to thank one of our sponsors. Luminova is one of our sponsors from November, and they created a UVB lamp. It's 95% UVB, and it's controlled by an app that it makes you put your skin type in. And after every session, it asks if there was any burning, and the app controls the timing of the lamp so that it's virtually, I mean, it's incredibly difficult to burn from it. And so, yeah, there's a varying qualities of lamps. I know a lot of people, they go to the tanning beds, and most of them have too much UVA, and that's why they've gotten such a bad rap. But there are other wavelengths like the infrared. I know Dr. Richard Chang is a huge fan of infrared. So yeah, it's just important to do your research and be mindful of the safety issues. Okay, so last question, Richard. His mother was told to stop taking all vitamin D because she has an overactive parathyroid gland. And his question, wouldn't a higher level of vitamin D3 dampen the parathyroid gland?
It's a good question, but also the tricky question, because I have seen in our clinics, we see many patients with the elevated PTH level considered as a hyperparathyroidism, but they were hyperparathyroid because of the vitamin D deficiency. So they are misdiagnosis as a parathyroidism, but they were secondary hyperparathyroidism because of vitamin D deficiency. So first thing to look at the vitamin D level, at least 25 hydroxy vitamin D level, and adjust the level. In 95% of the cases, the PTH level will come down when the vitamin D level reaches about 40 or 50 nanograms per milliliter. It's always settled down. On top of that, if the level remaining much higher, like 200 or whatever the level, it did not come down, then you can reassure that that's not the vitamin D effect deficiency, but now there is a true either primary or tertiary hyperparathyroidism. Tertiary means basically it's coming from the kidney, uh, the kidney failure and getting autonomous gland, or primary hyperparathyroidism, which is the most common abnormality in the parathyroid gland. There are four glands in the neck over here. So one of them has got a gland, but there is another genetic or condition called multiple endocrine neoplasia. They can have a more than one gland get affected with genetic abnormalities. So they can have a multiple gland with hyperplasia rather than glandular abnormalities. So all those are possibilities and need to be excluded. And new technique of imaging will very easy to categorize whether there's abdominal tumors on the neck or not. But trick is then there are rarely we see then the extraparathyroidal tumors producing PTH. That's the trick. When there's nothing in the neck, and you can even do a neck vein sampling and find that nothing there, but peripheral blood is high. So that means somewhere else is a tumor producing the PTH. So you have to do a whole body or some other scan to identify where that particular tumor is, which is very rare.
Right.
But 98% of the cases, parathyroid tumors are within within the neck itself. And the experienced hand with the parathyroid surgeons, which I have worked with for years, it's very easy to take them off
Right.
safely.
Well, thank you again, Dr. Wimalawansa. It was a pleasure. And one last question. Can we get a copy of your slides to share
I
along
think
with the recording?
it's best to look at the look at the video because there was no animation in the slides. So I prefer that everybody to watch the video with animation so that make more easy to understand what's going on with the video much more. And also they can stop where they want and read the entire slides through the
Mhm.
video.
Okay. And yes, the recording will be posted. Well, thanks again. Enjoy the rest of your Wednesday. If anybody has any additional questions, feedback, suggestions, please email me, jen@grassrootshealth.org, and anything directed to Dr. Wimalawansa, I am more than happy to forward. And so, any last comments, questions from you? Any last closing remarks?
No, yeah, thank you for inviting me for this interesting area. So just to let going back to the beginning of the talk, what I said that this is a very important, kind of complicated area, but unfortunately, hardly anybody knows about it. And if you ask 100 doctors, probably one, maybe two, may be aware of this. Having said that, the importance of calcium magnesium ratio on clinical medicine is huge because, as I said, then because in abnormal calcium magnesium ratio not only can cause diseases, it can make the existing diseases worse, can cause cancer itself. So, so it's a real problem not understanding or not giving attention to this simple issue. Therefore, the patients are getting suffered. The simple thing first, because if you understand and if you find that issue, the doctors or the nurses should be able to advise them on the lifestyle issue, but changing diets or taking some supplements appropriately or reducing the calcium or whatever the simple thing. And within a week or two, you can see a difference.
Yeah.
So why do you have to do all these expensive things and medication when you can do a thing in pennies?
Yes, simple, safe, inexpensive, and certainly important to know along with vitamin D. All right, everybody, thanks again. Thank you, Dr. Wimalawansa. It was a pleasure.
Thank you.
Enjoy the rest of your Wednesday.
Bye.
Bye.